Thank you. So I guess we have to run. So I'm going to talk about the preliminary clinical results of the total aortic arch endograft. And the authors here are, except for me, Yaniv Marmor is the engineer from the Endospan company, and Mario Lasha is from Switzerland. And disclosures are, I'm a consultant for Endospan, but also I'm an interventional cardiologist in a minority here. So, as you're all aware, there is a variety of etiologies linked to aneurysms, pseudoaneurysms, and dissections that affects the aortic arch. And you're probably aware of the different surgical and hybrid procedure offered to the patients, but unfortunately, all of these procedures carry a substantial risk of mortality and morbidity. And early experience with custom-made branch arch endografts showing promising results. However, the availability of these products are limited, and also the fact that it's custom-made takes a lot of time till you can offer it to the patient, and there's a big time lapse. Consequently, many patients remain untreated, and currently there is no off-the-shelf branch aortic arch endograft available in the market. There are obviously other options that all kind of you can use by your own toolbox, periscopes, snorkels, chimneys, in addition to conventional TEVARs. But the objective of our project was to create an off-the-shelf endovascular device that excludes the aneurysm without compromising perfusion to these great vessels and without causing arterial damage, especially in the ascending aorta. And there are a lot of challenges dealing with the aortic arch, including motion that are in different frequencies, both with the cardiac cycle and the respiratory cycle, and the arm and head movements, and also the variability between patients type 1, 2, 3, and bovine arch. And so we wanted to overcome these challenges. So this is the device. It's basically comprised of two modules. Module 1 is deployed from the innominate artery, which is the fixation site, to the arch, and another fixation site is in the descending with a fenestration towards the ascending aorta. And module 2 is the ascending module that has an overlap between these two modules, and that's how you both get fixation and sealing between these modules. There are two setups, one with and without supraortic fenestration that goes to the left common carotid, and I'll explain later where we do stand now with the preliminary experience. And basically the procedure is done over a through-and-through wire from the femoral artery to the brachial artery. You bring up the delivery system, which is a 20 French sheath. You orient it to the rotational orientation and deploy it from the innominate, open the fenestration and the overlap to the ascending and into the descending. There is a flow to the brain throughout the procedure. Then you bring up the ascending module and deploy it under rapid cardiac pacing. In place also rotational marker. You release, still you have flow, you release proximal and distal fixation, and basically that's it. However, going from the first-in or preclinical studies in animal to the first human study is very difficult, and there is a major change. So, and we felt very uncomfortable to offer it and to go to the first patient. So what we did is actually also, I think, kind of unique. We take each candidate and we print it. We take a 3D printer based on the CT scan, we print it on cast, and then we make a model from latex. We connect it to this simulator. This is not the patient, this is the engineer. And we connect it to flow, and 37 degrees. We have outflow to the great vessel here, and we deploy, we do the procedure one-to-one, and each patient goes first modeling in Hadassah in the cath lab, and we do the procedure. You can see here deploying the main module. I'll run it fast since we don't have much time. We make sure that we don't obstruct the right common carotid. We deploy the innominate, open the fenestration to the ascending, push the device to align it with the ascending, the final deployment, and then bring up we balloon, then we bring up the ascending module. Also a unique technique, endovascularly, we create a loop here in the aortic root and can bring it into the LV to avoid perforation or damage to the LV with this long tip. So we actually loop the wire here. We deploy the ascending module, release it, then final ballooning in the overlap, and then we can do completion angiography showing flow to the innominate and exclusion of the aneurysm. We then send, we already performed more than, actually today it's more than 30 models created for all the candidates, 2 to 5 procedures per each model. We do it first in Israel, then we go to the center abroad, and we do the rehearsal with the operators at the actual OR, and until the operators feel comfortable. This is the first time they're doing such a procedure, so we can do it once, twice, 3 times until they feel comfortable. And all patients enrolled so far, 16 patients have done the model. And this is only a partial list of the catalogs of our candidates. Each one of them is miserable in his own way. And this is how it's done. This is in Zurich. We do it 1 day before the procedure in the same OR. This is the patient connected to the simulator. And next day, we feel it's just like this deja vu, the same team doing now with blood and sterile, obviously. And you can see here how similar is the patient and the simulators. And it's really, really nice. So this is one patient before intervention. He had a prior TEVAR in the descending, and this is how it looks after the procedure. Obviously, you can see here there is only one fenestration to the supraortic vessels, and we need here, as you can see, a bypass for the right to left carotid, and the left carotid, left subclavian artery. So this is the screening process. We get the CT scan from the operators. We see if it's anatomically suitable. Then we create the model. Then we do the simulator. And then if all these pass, we go to the center and deploy and do the procedure. We had 11 patients done, or 5 first patients done with the double branch with the left common carotid and innominate, and 11 patients with a single branch. The fact that we changed was that this was the Achilles heel of the procedure, and it was quite a time-consuming step and very stressful step to try to cannulate through the fenestration to the left common carotid. So then we decided to stop and go back to the R&D process, and now we are working on a pre-cannulated wire that will ease the procedure and make sure that we can definitely cannulate the fenestration easily and go into the left common carotid. So currently we're offering only the single fenestration. Regarding the supraortic vessels, we had a supraortic bypass in 15 patients, periscopes, which means a parallel graft from the descending to the mainly left subclavian in 6 patients, chimney from the ascending to the left common carotid in 1 patient, and the branching in 1 patient. There are 2 clinical pathways. First, in men studies, we done in Czech Republic, Switzerland, and Rome, and compassionate use, which is open worldwide in Canada, Zurich, Rome, Modena, Toronto, and San Donato. Totally 60 patients in 7 implantation sites. And if we look at the initial preliminary results of these 16 patients, so technical success was 100%. Mortality was 13%. 1 patient died of pulmonary complications, couldn't get the pneumonia post-op, and the other one had actually a dissection, complicated the procedure. A stroke rate was not negligible, obviously 25%, and we know and we aware that this may be the Achilles heel of the whole procedure, but fortunately no permanent deficit. Spinal cord ischemia in one patient, and endoleak type 1A or 3 in more than 30 days was 12%. If we stratify and we take only the single fenestration setup, so we had actually no strokes and no endoleaks. Obviously, there is also learning curve, but these were the latest 11 patients. This is not the first 5 patients. So to conclude this initial experience with the 16 patient, the next aortic arch treatment has demonstrated safety and the ability to treat a very challenging portion of the aorta. This promising concept had no specific device-related events during the implantation and good short-term follow-up. Obviously, long-term follow-up is in process. So to summarize, this is historically a surgical disease. However, surgery is not an option for the majority of patients. We used highly innovative endovascular solutions, many features to enable off-the-shelf device for complex variable anatomy. And we have a unique pre-procedural planning and training. And we still aware of the challenges, and we continue our R&D process for the remaining challenges. And this is all made in Israel, except for the patients. So compassionate cases are welcomed. If you have, just bring up and we can do it. We had one candidate actually from Ichilov, but unfortunately after modeling him, we thought he's unsuitable for the Nexus. Thank you.